There we go. Okay. So with EKGs, I've already made one movie reference already, but has anybody seen the movie The Matrix?
Oh, yeah.
Yeah. And so if you've seen it, you can maybe remember they live in a world where you look at a computer screen and you can kind of see what's happening in this digital world. And, like you'll see like these people, these characters, and they're watching all these ones and zeros fly across the screen. And they're like, oh, yeah, this is happening to this. And look, and he knows Kung Fu and all these things. So I think that EKGs are kind of similar, where you see something go across the screen, and maybe it's not ones and zeros, it's kind of squiggly lines. But based on those lines, you can kind of interpret what's going on with the patient. I think with EKG interpretations, part of it is memorization. Some of it you just have to memorize the steps and a few of the measurements. And then some of it is also that critical thinking of what does this mean for my patients? We're not going to get super in depth. You guys have you gone over 12 leads in your lab class, how to do those, where you hook on the 10 stickers onto patients? So 12 lead EKGs, those give you it's 12 different views of the heart. We're just doing simple EKG interpretation. 12 leads are a lot more complex. If you go on to get your RN or further degrees, you might go on and learn how to interpret those. But we're going for simple EKG interpretation. And what I want you guys to know is what's abnormal, what are the common, or pardon me, what's normal, what are common abnormals, and what's going to kill it, right? Like, what are the deadly events? We need to know those simple things, kind of like how you guys learned in your assessments. You're like, oh man, is this wheezes? Is this rhonchi? What does this mean? What I want you first to be able to do is just identify what's not normal. So if you think about that, look for something. If it's not normal, then I'm gonna teach you how to go through and figure out how to interpret what that abnormal means. So first, I have another fun, I think everything's fun, video from Osmosis that does talk about EKGs. Let me get out of here. 1 second. Like we're only watching half of this, but I don't remember. So whenever I think we're done with, because we're only doing part of this video, I'll come up and stop it. Can you guys hear okay?
An electrocardiogram, commonly referred to as an ECG, is a routine, non-invasive diagnostic test that uses electrodes placed on the skin to provide a graphic representation or picture of cardiac electrical activity. The standard ECG is also known as a 12-lead resting ECG because it has 12 leads or sets of electrodes. These include 6 limb leads, which are placed on the arms and legs, and 6 precordial leads, which are placed around the
Yeah. All right. Sorry about that, guys.
also known as a 12-lead resting ECG because it has 12 leads or sets of electrodes. These include 6 limb leads, which are placed on the arms and legs, and 6 precordial leads, which are placed around the chest. Keep in mind that a 12-lead ECG only uses 10 electrodes. That's because the chest electrodes record 1 lead each, while the limb detectors together actually record 6 leads. Now, let's quickly review the electrophysiology of the heart. The cardiac conduction system is made up of specialized myocardial cells that can create and send an electrical impulse, also called an action potential. These cells have many special features, including automaticity, meaning they can generate an impulse by themselves, conductivity, meaning they can carry the impulse to other cells, and contractility, which is the ability to shorten the length of their fibers, causing a contraction. The way it goes is that the electric impulses begin in the sinoatrial or SA node, which is located at the junction of the superior vena cava and right atrium. The SA node is considered the pacemaker of the heart and spontaneously and rhythmically produces impulses at 60 to 100 beats per minute. The impulse then moves quickly through the atrial muscle, causing depolarization. When the atrial muscle cells get depolarized, they contract, pushing blood from the atria into the ventricles. Meanwhile, the impulse lands at the atrioventricular or AV node, which lies at the lower back section of the septum that separates the right and left atria. Conduction velocity, or the speed at which the impulse is propagated, slows way down in the AV node. This allows time for the atria to contract while the ventricle fills. From the AV node, the depolarization wave travels through the conducting system of the ventricle. First, it goes into the bundle of His, and then into the left and right bundle branches and into the Purkinje fibers. The Purkinje fibers are the final bit of conductive tissue that spreads the depolarization wave to the rest of the heart. The His Purkinje system conducts the depolarization wave really quickly, and this is important because it makes the heart contract in a coordinated way. This makes up the systole, where blood is ejected into the pulmonary and systemic circulations. Finally, the ventricles repolarize to prepare for the next cycle, which allows them to relax and fill with blood, called diastole. Now, the function of the heart's conduction system is typically assessed using an ECG tracing, which shows how the depolarization wave moves during each heartbeat. So in a typical waveform, there's a P wave, which represents the depolarization of the atria, a QRS complex, which represents depolarization of the ventricles, and a T wave, which represents the repolarization of the ventricles. Sometimes, immediately after the T wave, there's a U wave, which represents late repolarization of the ventricles. In addition, there are certain intervals and segments. So there's the PR interval, which spans from the beginning of the P wave to the beginning of the QRS complex, and it represents the time it took for the impulse to travel from the SA node to the Purkinje fiber network. And that's actually the time from the beginning of the atrial depolarization to the beginning of ventricular depolarization. Within this time is the PR segment, the time between the end of the P wave and the beginning of the QRS complex, which represents the time required for the impulse to travel through the AV node to the Purkinje fibers. Then there's the QT interval, which spans from the beginning of the QRS complex to the end of the T wave. It represents ventricular systole, which is the entire span from depolarization through repolarization. Within the QT interval, there's the ST segment, which spans from the end of the QRS complex, called the J point, to the end of the T wave, and represents the time between ventricular depolarization and repolarization. All right, so the findings of a normal ECG indicate a normal sinus rhythm and normal cardiac electrical activity. The ECG paper has large squares with big lines, and inside each are 25 smaller squares with thinner lines. Horizontally, each small square represents 0.04 seconds. Vertically, each small square represents 0.1 millivolts. There are 8 main things to look for on an ECG to ensure everything is normal. First, the heart rate can be calculated by counting the number of QRS complexes in 6 seconds and multiplying that number by 10. Secondly, the heart rhythm regularity can be assessed by checking the distance between the peaks of 2 consecutive P waves and 2 consecutive R waves. If the ratio of the PP and RR intervals is 1, then the heart rhythm is regular. Thirdly, the P wave should be checked to ensure it is present, regular in timing and shape, and that there is 1 for each QRS complex. Fourth, the PR interval is checked to make sure it's consistently between 0.12 to 0.20 seconds, which is 3 to 5 little boxes. Fifth, the QRS duration should be consistently less than 0.1 second, which is 2.5 little boxes. Sixth, The ST segment should not be elevated or depressed more than one small box. 7. The T wave shape should be asymmetric and height should be less than 5 milliliters in precordial leads and less than 10 millimeters in limb leads. And finally, the QT interval should be less than or equal to half of a cardiac cycle, which can be calculated by measuring the distance between two successive R waves. All right, let's take a look at the nursing care you'll be providing for a client who is receiving an electrocardiogram test with a 12-lead ECG. Start by explaining that an ECG test.
Okay. The rest of the video really just goes over like what you've learned in skills lab of how to perform an EKG or ECG. Bum, bum, bum. Okay, so we're gonna just review a lot of what that just talked about.
So all of my crazy writing up here will have purpose. One of the things I wanted to remind you guys of the blood flow through the heart. You remember the heart, it's a pump and it is a muscle, right? That muscle is what pumps the heart. But what causes it to pump is the electrical current that goes through the heart. So the blood flow comes in through the superior aortic cava, right? Through the right atrium. Then it moves down to the right ventricle. It pumps out and then goes where? To the lungs, right? And then from the lungs, it comes back into the left atrium and then to the left ventricle and then out to the heart with the ascending and descending aorta. Similarly, you can kind of see where the electrical current is it's kind of similar in how it works. You have the SA node that typically is about right here in the right atrium. That's what's called usually the pacemaker of the heart. It's kind of the boss. If the SA node is working correctly and everything else is falling into place, you're going to have a normal heart rhythm. Sinoatrial node is the forward. SA node is pretty much what you're going to see in most of your charts or your rhythm interpretation. So the impulses that it sends are usually 60 to 100 impulses per minute. What does that seem to line up with?
Your heart rate.
A normal heart rate, right? Because a normal heart rate, normal pulse that we feel should be what the heart is doing normally, and normal means SA node is the boss, right? Now we also have this atrioventricular node. Now this one is important too. And like the video said, everything kind of slows down when it hits the AV node. It allows for everything, the current to kind of flow down and all the chambers to fill. But because this is slowed down, if something is happening up here that's strange, not working right, it's not being boss-like, the AV node is kind of taking control. It's a slower rate. We're not going to learn a lot of the ventricular rhythms, but just know if your heart rate is really low, you think there might be something going on with the really high or really low. Might be something going on with this SA node where the AV node has to step in. Now, once the AV node gets its trigger, and the SA node, it does come through over to this left side as well, right? It's a little bit stronger on this right side, but it also is contracting the left side, left atrium as well. When it travels down, it actually kind of travels through the middle of the heart and kind of sends these currents so that the ventricles contract, right? This is contracting to send the blood to the lungs. And over here, this is contracting to go through the ascending aorta. That kind of makes sense how we have both the blood flow and the electrical conduction. How they both, I think to understand one, we have to understand the other. We have to understand how the electrical signal gets sent through. That's why blood flows in the right way, right? Because we have these chambers in our heart and we have these valves, but if for some reason we're getting things aren't firing where they should, we're not going to get an effective heartbeat, right? It's not going to go like it should. I don't have a Menti for you just because we have a lot of hands-on stuff. So I just have PowerPoint today. Just so you know, the AV node if it decides to be the boss, it's in charge, usually about 40 to 60 beats per minute. You're gonna see a real low heartbeat. If the SA node kind of checks out, it's like, not functioning. Then you're gonna see this. You might see somebody, well, I had one of my clinicals this last week, one of my students had a patient that had sick sinus syndrome. What that means is that the sinus node, they call it sick, it was malfunctioning. This patient's heart rate was very low because the sinus node had checked out. So the AV node, it's like, hey, my boss didn't show up. I guess I'm gonna take over, not gonna do as good of a job, but I'm gonna get something done. Its rate that it will conduct if it's the boss is lower than 60 per minute. Doesn't mean that somebody always, if your patient's heart rate is 56, they might just be in really good shape. They might be a runner, they might have a more effective pump. But if they are not looking so good, not super healthy, they're diaphoretic and pale, I might think, ooh, if that heart rate's really low, it might be the ventricle or the AV node that's kind of the boss right now. Once it goes through the AV node, it goes through this bundle like this, goes through the junky fibers, or Purkinje, we're not going to go through all of those. Those are more important if we would talk about blocks, and we're not really going to talk about blocks today. Block just means when you do study, if you go on in your schooling and you talk about blocks, that just means maybe something's happening where the SA node is sending its electrical impulse. Nope. And something's happening where it's not getting to the AV node like it should. And it makes it take longer than it should to transmit the signal. Now, when you start looking at interpretation, it's with this like special paper that we use, and that's how we know how long it takes, because that electrical signal actually shows up. Like we found a way of tracing it on paper, and so if something is kind of longer or it's not what it should be, it's letting us know that the signal isn't getting sent through like it should. That's all I'm gonna really talk about blocks for right now. All right, we talked about the conduction system, 1 heartbeats, right? We talked about that. The video talked a bit about the components. So I almost want you guys to get in that mind where you're in the matrix, where you can think through and be like, okay, P wave, atrial, QRS, which is the big whoop, whoop, that's the ventricles doing their thing. And then we have this T wave, and that's the ventricles repolarizing. That's when they're kind of getting ready for the next electrical signal to go through. So when we look at this is 1 cardiac cycle. That's what we're seeing when we see the impulse start here at the SA node. That P wave is that wave of electricity flowing through the atrium. And then the QRS is when we have it deployed through the ventricles. Does that kind of make sense? Anybody totally lost right now? We're okay. All right, hang in there. So the electrocardiogram, we're looking at the electrical activity. The 12 lead, sometimes you guys will notice if you practice 12 leads in the lab, there's only 10 stickers. That's because it shows you 12 different views. With those 10 stickers, kind of like if you put like 10 cameras around the room, you could combine some of those viewpoints to establish another viewpoint. So that's why it's called 12 lead. They actually get 12 little view loops. The waveform changed the appearance, meaning that when you have that 12 lead, if you are looking at the lead that's going to be up here on the chest, you're going to see something that's more like a normal sinus rhythm that you might see in your papers. If you're looking at a waveform that's maybe in one of your lower, like on your legs, it's going to be inverted. It's going to look opposite. Why might that be? You're looking at a different angle. So up here, this is our patient, and we've got a lead up on their chest here. Our view is looking down like this. Now, if we have a lead that's down here on the legs, that view is looking up this way. So it's just a different point. So make sure you know which lead you're looking at. Most of the times, lead 1, 2, sometimes 5 is what people will look at.
And those will show what we typically look at and see what we've learned how to do normal sinus rhythms. Sometimes if your leads look, or like if what you're tracing looks really strange, I want you guys to check your placement, right? Because if somebody has maybe their leads all in a funky way, that's going to change what your EKG tracing looks like. Okay, because it's just a picture. It's a viewpoint looking at the heart of the electrical activity. Like it said, lead 2 often is what we use for our continuous waveform tracing. The paper, right? So when we look at our paper, and you guys have like just in general, like just some extra papers I put there. But what we're looking at is when we go across this way, we always go left to right. This is measuring time. When we go up and down, that's measuring voltage. That's how much current is going through the heart. Now it makes sense that that P wave, it's smaller than QRS, right? Because when you look here, we have the signal, but there's a lot more electricity just from the size of the ventricles that's flowing through. And that's where that QRS is a lot larger. There's more voltage in that. Now, when you have those boxes, those ones are 0.04 seconds each. Sometimes when we get to measuring, you guys do want to know that. But you want to know these bigger boxes are oh, I put that wrong. It's 0.2, isn't it? Yeah, it's 0.2 seconds. Am I wrong? Fact check me. Yeah, okay. I can do some math. Yeah, so the bigger boxes are 0.2 seconds. Do I ever put trailing zeros on? No, we usually don't. Leading zeros only if it's a point, decimal point, right? You usually don't want to do trailing zeros. Okay. So, what's what I'm gonna say? When you guys look at your strips, like in the examples that I gave you, most of these are going to be what's called 6-second strips, meaning that if you count up all of these boxes, it should be right about 6 seconds in length. Why do you think everybody standardizes their strips to be a 6-second strip? Right, because it makes it so much easier just to say, okay, multiplied by 10, that's 1 full minute, and then I could get my heart rate. And with 6 seconds, you usually have several, if not many, total cardiac cycles that are on there. So you're able to get a good picture of what's going on. Because if we just have enough to see one heartbeat, one electrical cycle, it might not tell us the full picture. We need several heartbeats in a row or several electrical conduction cycles to really see what's happening with our patient. When you guys have a test or quiz, anything with me, it's always going to be a 6-second strip. So I'm not going to make you go through and count how long is this whole thing. Just assume everything is a 6-second strip. All right, we talked about the graph paper. Okay, so think back to our reading. When there's nothing happening on this tracing, it's just a flat line. You remember what that's called, or what the name of it is? Isoelectric clock. When the EKG is just in that flat area. So, boo, boo, boo. I guess I have to draw something out. Fun. All right, so normal sinus rhythm. We're going to have a P wave, a QRS, T wave, and then after a little bit of time, we're going to have another P wave, QRS, and T wave. And it's not like the most beautiful rendition here, but bear with me because this flat line here, 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 that's the isoelectrical line. That's what we're looking for. Anytime we have an EKG tracing, we want to see where is it flat, because that lets us know kind of where
like, yeah, baseline, where baseline is at. And just like with my drawing, it's not always exactly flat or exactly straight, right? It might change and move just a little bit. All right, so question up here on the EKG paper, one small square, the little bitties. Don't look at the board. How long are they? 0.04 seconds. Yeah, number 2. So the P wave. The P wave is the first wave. And what does it measure? I know I keep putting things on here. Atrial depolarization, right? And then we want to look at the PR interval. That's the next thing when we're looking. That's the next part of like when we're looking at this conduction cycle. And that means how long is it from when the P wave starts till the QRS starts? Now remember, when we're looking at our conduction system, that's important because it lets us know, hey, when the SA node is the boss right now, if it fires, we want to know how long before it fires does it take to travel down and start the QRS or start the ventricles firing. Okay, so that's what we're looking at in the PR interval. We want to know how long does it take. PR interval, normal is 1 to 2, well, I should say it's normally 0.12 to 0.20 seconds. So it might be 3 of these little boxes or a whole, like one of these bigger boxes. That's about how wide it should be. When we measure our QRS complex, you're looking for that isoelectric line again, right? We're like, okay, we got through the P wave, and then we're like, okay, we're back to isoelectric. The minute that we see it, or not the minute, but the point at where we see it deflect to go either up or down to when it goes back to that isoelectric line. That's what we're measuring. From when it deviates from isoelectric and comes back to isoelectric line. That's what we're measuring. And again, remember we talked about blocks, and I'm not going to go into those a lot, but if it's very wide, the length is taking longer, it might mean that we do have something that's blocking the conduction system going through. That's what blocks mean. It's just something's blocking that conduction system. All right, so the PR interval, oh, I should have gone here. This is a beautiful picture of it. So here you see P wave, right where it starts. And don't you love how in the textbooks, they have it perfectly straight and the P wave begins right on one of these lines? Never happens in real life, but that's okay. We're gonna enjoy this while we have the textbook picture. So it's when the P wave begins and then over to where that QRS just begins to deflect. That's our PR interval. So if we were going to measure that, how would we do that? We would count the boxes, right? So how much is one box? 0.04. So 0.04 times 1, 2, 3, 4 is 0.16. Now, is that normal? Yes, it is, because it can be 0.12 to 0.20. Saying that right, yes. So that's good. We got a normal one. So now QRS. I'm not going to break it all down for you for looking at the Q, the R, and the S, but just know generally we talk about being a QRS. That's the main big jolt that's sent after the P wave. I'm not always going to see QRS all like up, down, So just know in a real patient, you might just see one big up and down, or you might see one down and up. It depends on that patient's, their heart, if they've had any damage or anything. And the QRS complex, it just represents the ventricles depolarizing. So with the QRS, this kind of gives you a little bit of a example of how QRS waves look a little bit different, right? Sometimes you might be able to see the Q as it deflects, the R as it goes up, and then the S as it deflects again. That's really beautiful. I can see all of those, that bundle all together. Sometimes you can't see anything but the R. Either way, we are always going to call this a QRS complex because like in the R, it's just that the Q and S are just kind of hidden in there. It's not that it's not happening, we just can't see it very well. And we still refer to it as the QRS complex, and we still hold it to the same standard, meaning we want it to be about 0.1 or 0.10 seconds or less. That's about how long we expect the QRS complex to be. And when we, oh, I wrote that wrong on here. Okay, I was wondering about that. So the QRS complex, that's what should be 0.1 or less seconds. The QRS interval, now we're looking at intervals, we're looking at how long does it take from when we start one QRS, when we repolarize the ventricles, to when it happens again. What's happening in our bodies physiologically with our pump? The heartbeat, right? That's just the time between one heartbeat and the next. So if we can kind of put these together, if we can kind of marry those ideas in our mind, I think it helps it to be a little bit easier. So here, this is our QRS complex. Again, isn't this beautiful how they have it lined up right at the beginning of a line? So let's count how long this QRS complex is. So it starts to deviate. So this is where we start it. And then it ends its deviation kind of right in the middle here. So how long is this QRS complex? 8 seconds. About, and not seconds, but it is 0.10 seconds. If it's right in the middle, we just say, well, we know the box is 0.04 seconds. So half of it is 0.02. So 0.04 plus 0.04 plus 0.2, that's right about 10. I'll go into some tricks on measuring a little bit later. All right, the T wave, that's what happens once the ventricles are repolarizing. Everything's kind of relaxing, getting ready to fill back up. It's after the QRS complex. Sometimes your T wave, if you've had some damage to your heart, instead of being nice and upright like this, it might be inverted or upside down. And it's not the same as if we're looking like from one of those leads that are like on the legs, because if you're looking at a leg lead, everything's going to be inverted. This is where we're still looking maybe on V2 or something, one of those leads that will look normal. And everything else is doing what it like normally would do, but then that T wave is inverted. That means that there's some damage. What it really means is that that signal, how we normally see it, it's having to go around somewhere else. There's some damaged tissue, so it's taking an alternate route. That's why we're seeing it look a little bit different. All right, the QT interval. I'm not going to talk a lot about it. We're really not going to measure it. I just want you guys to know QT interval, that's from when the QRS starts till the end of the T wave. There are some things that if your T wave gets longer and longer, we get worried about that because we might it might cause arrhythmias. We're not going to measure that today. We don't have to worry about QT intervals. Every once in a while, you could have what's called a U wave. I personally have never seen one. Usually happens with some potassium imbalances, like low potassium, and it looks kind of like this, where you have an extra little U wave on there. So I'd love to see one. It's my hope, like it's like seeing a narwhal or a unicorn. But like maybe someday I'll get to see a U wave. So the ST segment, again, I'm not going to talk about this a whole lot, but that's from the end of the QRS complex to the beginning of the T wave. Again, if it's inverted or depressed, that might mean there's some damage to the heart. So you can see on this one how it doesn't ever even come back up to the isoelectric line, right? It's not just inverted going down, it's also totally depressed where it doesn't come back to that isoelectric line. You could also have these big elevations of the ST segment. Anybody ever heard of a term called tombstone T waves? No? So when you're having a heart attack and a lot of damage to your muscle, usually when it's actively happening, you can have these big, large T waves. And they call them tombstone because they look kind of like a gravestone. And oftentimes it signals that they're having some massive damage to their heart. And that, death is definitely something we're trying to avoid. So when you think about T waves, if they're big and like pronounced, or they're building off of the QRS like that, think bad, tombstone. This patient's probably not doing good. I want to look at that. All right, so PR interval. What are we measuring when we're looking at PR interval? Yeah. How long? Remember, how long does it take for this signal to get from the SA node down to the QRS, or to the ventricles, which is beginning to the beginning. That's our PR interval. And how long is it? Number 3 is correct. And these are some of the things you guys are going to have to memorize, because as you start doing interpretation of these rhythms, you got to remember there's not a whole lot I'm asking you guys to remember as far as those numbers, but this is one of those things you need to know. So the 6-step process of how do we interpret these things. So go ahead and grab your paper that I gave you that, when you hold yours up, kind of looks like that. Is it front and back? Is it front? Well, did everybody get both sheets? No? Okay, maybe pass these around. You can read on the other side of the sheet. The copier didn't staple them, and then I didn't have time to go through and staple them for you. So the handouts that we have, so many handouts today. The one that is stapled, that's in black and white, those are meant to be used like flashcards. If you cut them up, you'd be able to flip them back and forth and see one side will have the rhythm and the other side will have the interpretation and the standard measurements for that. So that's really just to help you study. The handout that I have, it kind of helps to define that six-step process that we're going to go through. So I want you to get your handout ready, because we're going to be using that as we look at this 6-step process. All right, so regularity. What does regularity mean?
It's regular.
Yeah. Is it regular or is it not? Or is it irregular, right? That might be the opposite, the other piece to it. Let's just go and look at regularity first. So here you can measure it a couple ways. So look at your first normal sinus rhythm on your handout, okay? And see how it has like the little line between the two QRS complex. All right, back when I was a young thing learning how to do EKG interpretation and measurements, we used calipers. I've never seen anybody with calipers, like hardly ever, but they were it's like a little thing that spreads apart and it has 2 little sharp parts on it. And you would go up to your EKG and you would use your calipers and you would go, okay, from here to here, and then you would march it out. Bloop, bloop, bloop. That's really, nobody carries calipers. First of all, they get lost, and then you lose the cap and they're really sharp and you stab yourself in the leg. So I'm going to tell you guys how you can also measure distance without using calipers. I like to just get a piece of paper. That's why I gave you guys just blank sheets of paper. So what you can do is get your paper. I know mine's not long enough, right? Let's do. This is a really bad EKG, you guys. But essentially, you're going to line up whatever you're trying to measure, and we're going to try to measure regularity. All right. So you're going to put your paper and you're going to get either at the beginning or the top of your QRS. I'm going to do the beginning of my QRS, and I'm going to make a mark. And I'm going to make a mark. So it lines up exactly with the beginning of one QRS to the next. Now that I have my measurement I'm gonna march that along the rhythm. I'm gonna say, okay, here it lines up. Here, doesn't really line up. Here it doesn't line up. I want you guys to march your little measurement along your path. You practice? Yeah, actively practice doing this. Yeah, just like that. You know, yes. All right, which one do you need? There you go. Okay, great question. So over here, I want you to make sure one measurement. You start with just one piece and you move that down. You don't keep measuring. So you take this one measurement and then you move it down. Exactly. Make sure they're happening. So I just do one. So, yeah, beginning of it, another one.
Oh, and they're alive.
Yeah.
They're breathing.
And you don't even have to, just be. The whole.
They're like-
Move it down. So that's really not up. They remove it and then keep going down.
Oh, no.
Oh, okay. If you feel like you have it really good, check with your neighbor. So you want to put it on the paper. There, and then on the next QRS. Then we have our measurement. So then we go down. 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 We want to see if everything measures up. How are you guys doing? You did my sinus rhythm and we're practicing this one, and the other side of this one, just for now. Yeah, where's your mental? Oh, yeah, so I, sorry, I heard you say this. Mark it down and make sure. Just one, and then we use that. It does, yeah, you're right. Guys kind of feel like you got moving one down, okay. All right, so if that part takes the longest to make sure that everybody's on the same page of how we measure. I think learning that paper way of doing it is the easiest because you're always gonna have paper wherever you are. You might not have calipers or some of the other tools. Actually, most of the time, if you ever work in a tele room, now it's electronic and you click. And when you click on the rhythm, anybody done rhythm monitoring or tele room? Yeah, and you can click on it, right? And you just like, bloop, and it like when you end, it just says, this is 0.23 seconds or whatever. Like it just gives you like the measurements already. But I still kind of eyeball and double check my measurements because I want to make sure it looks right still. Okay, so when we're measuring, that's one way of measuring the regularity is the QRS complexes. We could also go down and instead of making our marks at the QRS, we could measure them at the P waves as well, right? It's the exact same concept, except for instead of starting at the beginning of the QRS, making our two little dash marks, one here and here, we're just gonna move it back from P wave to P wave and then move that over and see if that's equal. Does that make sense? So that's telling us, is it regular? I want you guys to go over to, let's look at atrial flutter. So you should have one, I think it's on the second page that says atrial flutter. And I want you to measure the distance between the QRS complexes. So measure 2 points from that first QRS complex to the second, and then march that out and see if it's regular. Yep. I want you to measure the QRS complex.
Extra space.
Oh, wait, I think I do.
Perfect.
Wait, yeah.
You should have 2. No. Let's keep that. You want those 2.
Oh,
Okay,
okay.
Okay, who is missing one?
Maybe you guys should do something right now.
I look
Or you
like
do
that
it
too.
too.
Yeah.
Yeah, okay, it's perfect. So maybe help her go through like where do you measure?
Okay, how are we feeling about the atrial flutter?
It's normal.
Normal. Once you've done the atrial flutter, I want you to go to the one down below it and look at the atrial fib and measure that one.
Okay, as Raheem just so comically pointed out, we can look at it and tell it's not normal. But there's gonna be sometimes when the rhythms are a little tricky, when they look fairly normal, but they're not. So it's important to just, if you are not absolutely sure, and if you're not well experienced with this, you might want to just go ahead and measure. Now, I will say, we are looking at beautiful textbook EKGs right now. In real life, as a person moves through their life, as they breathe and as they walk, your heart rate fluctuates, right? Your heart rate doesn't always stay right at 75 beats per minute, right? As I start walking across the room, or if a doctor comes and talks to me, my heart rate might start going up. So you might actually see some changes in this normal rhythm that you have. That's still normal, okay? We just want to still check. All right, so we talked about the first step is establishing, is it regular or is it irregular? That's going to let us know, kind of to be helped to interpret the rhythm. Boom, boom, boom. So how do we calculate the rate? So now that we've established, so that we already established ours, so for the, we're still going back to the sinus rhythm one, okay? That's what we're starting with. We've established the sinus rhythm is regular. Now we want to calculate the rate. So all of your strips that you have are 6-second strips. So what you're going to do is count each electrical or each cardiac current, each cardiac cycle, and see how many of them there are on that strip. Generally, I choose to just count each QRS complex. That's usually the easiest way to do it. So in your head, go through and count how many QRS complexes you see on that normal sinus 6-second strip. All right, what did we get when we counted that? 7? 7, right. And we multiply it by 10 to give us our heart rate.
So 7 times 10 would be 70. Hey, that lines up with our SA node pacemaker being between 60 and 100, right? I like that. Go really quick to that other page that had B or A fib. Ventricular tachycardia. That's on the back page. You don't have to measure anything. I just want you to count. How many big QRS complexes do you see on that page? Ventricular tachycardia. How many QRS complexes are in the ventricular tachycardia rhythm? Yeah, I hear 18. So if we're multiplying that by 10, what is our heart rate? 180. Is that patient going to be feeling very good?
No.
No, absolutely not. Because we remember that means that something is wrong with our electrical current, right? Clearly, we are going way too fast. But if you remember the blood flow through the heart, as the ventricles relax, or all the chambers, as they relax, they fill back up with blood, and then they contract out that blood. If our heart is beating too fast, we're not allowing time for those ventricles to relax and fill back up with blood. So even though it's pumping really fast, it's not pumping out very much because we're not allowing much time to get more blood in there to push back out. So when the heart rate goes really high like that, what's going to happen to our blood pressure? It's going to go down. It's going to go down because it's pumping so fast. There's not very much in the chamber to pump out. Our cardiac output is going to go down quite a bit. All right, so we figured out a little. I have another board. Oh, I got so Margaret happy yesterday. So we figured out if it's regular, the R to R or the Q to Q. We figured out what's the rate, right? It's always going to be 6-second strips. Now we're going to look and say, are there P waves? We know what P waves are, right? They're the little ones that come before the QRS. Oh, I forgot to say, irregular rhythm, both regular and irregular, you just count the QRS complexes. Yeah. Bum, bum, bum. Oh, this wants me to talk about normal sinus. Okay, let's talk about normal sinus rhythm really quick. This is normally, if the sinus SA node, if that's in charge, then we're going to see the normal sinus rhythm. Okay. Now I want you guys to get used to saying normal sinus rhythm because there's some other rhythms that can be stimulated from this SA node that aren't normal. They can still be abnormal rhythms that still start at the sinus node. So normal sinus rhythm, you have your heart rate, right? Between 60 and 100 beats per minute. Your P wave, it's nice and tidy right before every QRS complex. When you look at it, you're like, oh, there's a P wave with each QRS complex. Look at your sheet that has your normal sinus rhythm. You should have you should be able to see a nice little QRS. You should see a nice P wave, a QRS, and a T wave, and then a P wave, QRS, T wave. They should all look normal. They should look the same. They should be equal distance apart. On a normal sinus rhythm, if you measure the P wave to the next P wave, or you measure the QRS from the next QRS, it should all match if you march it down on your sheet. The PR interval should always be 0.12 to 0.20, just like we talked about, that's normal. And the QRS should be nice and kind of small. It shouldn't take very long for that, for the ventricles to polarize, go through. Oh Lord, what did I just turn it off? I didn't know I could do that. Oh. Okay, sorry, new things. Let's talk about arrhythmias. So normal sinus rhythm, that's normal. Arrhythmias is any time we deviate from that normal sinus rhythm or rhythm. So if you see something in a patient's chart, one of their diagnosis of having an arrhythmia, that means that there's something that's different from that normal sinus rhythm. It might mean they have atrial fibrillation. We've talked a little bit about that before. It might mean they have some abnormal ventricle beats in them. It might mean a variety of things. They might have a type of a block. It doesn't tell us really much other than there's something that's not normal. So if your patient's chart says arrhythmia, I want you to go in and look and see what kind of arrhythmia, because depending on what kind of arrhythmia, that might mean they need to be on some medication to help steady the heart. They might need to have a pacemaker put in. They might need a variety. That means it could be anything. So we're going to talk about our sinus arrhythmias. All right, so sinus bradycardia and sinus tachycardia. Just looking at it, what do you think the bradycardia means? Slow. So what's the rate going to be on our sinus bradycardia? Less than 60. It's going to look in every way the same as our normal sinus rhythm, except for that rate, when we march it out, is going to be slower. So look on your handout at the sinus bradycardia. I want you to go ahead and measure from one QRS complex to the next. Make sure that we have a regular rate, oh Lord, and that it marches out that it's regular. So when you measure this, if you count the QRS complexes, what is our rate for this sinus bradycardia strip that I gave you? 40, yeah. What are we gonna do with our patient whose heart rate's 40?
We are going to probably want to do something.
Well, we're gonna wanna do something.
Yeah, we're gonna monitor it. We're gonna get some meds to maybe get that heart rate going.
Yeah. I'm gonna tell you guys, the first thing you're gonna do with any rhythm that looks strange is you're gonna go look at your patient.
Yeah.
Okay? There's some Olympic athletes whose rhythm strips might look like this because their heart is so efficient.
Yeah.
There's also gonna be some really sick people who aren't doing so good. There's gonna be patients who aren't doing so good whose rhythm looks the same. So the rhythm that we see on our paper or on our screen, it gives us information, but I want you to put your eyeballs on the person, okay? We're gonna talk more about how it can really be
If your
tricky.
patient is sleeping, do you wake them up? If their heart rate is
Depending
like
on
that?
what the rhythm is, yeah.
Okay.
Yeah, because if I think there's something going on, if I start seeing those tombstone T waves, I might go, oh my gosh, you might be sleeping through a heart attack. I want to see what do you feel? What's
Yeah.
happening right now? All right, sinus tachycardia. Look at your sheet where it says sinus tachycardia. I want you to we're going to practice measuring so you guys can do this in your sleep.
I want you to check to see if it's regular. So measure out QR intervals. Or the Q, pardon me, Q. The
Yeah, the
QRS interval. QRS interval.
I'm going to get more water.
All right, what is the rate that we have on this? How many QRS complexes? 12, thank you. Yeah, we have 12. We multiply it by 10 to get 120 for our heart rate. Now, we didn't do this with sinus bradycardia, I forgot. But if we're looking at any kind of sinus rhythm, we really should still be looking at the PR interval and the QRS complex. So for the sinus tachycardia, I want you to go measure what is the PR interval. Beginning of the T wave to the beginning of the QRS complex. Now you don't want to march this out necessarily, you just want to see how long it is. Then, because maybe it doesn't line up on those boxes perfectly, you take your measurement and then you go over to your then you just go over to your sheet that has the boxes and you take your measurements and then you line up your measurements on the lines, which you can measure. Let's see how long. PR measure on here from the T wave to where the QRS starts. It's very small. From the T wave, there it starts to where the QRS comes. Where it starts. Because it's still it ends right at the end of the each story is there.
So we start here. And I think you start from here.
So once you measure that out, or you got your length, were you able to hold it against the boxes and see how long that was? Yeah.
Yeah, so you want to start right where the B wave begins, and then you go as you go. Sometimes you get something that's left either up or down, so it just starts to go down. That's where I would mark it. So then I'll look here. Yep, and then you measure, if you count up those boxes, sometimes you start right on the line. Then you would write up paper and just measure them back. Yep, 12, 13. Right about in there. You guys feel good about measuring? How are you guys feeling with that? It is hard to see the boxes, isn't it? Yeah.
Is anybody get a number that is lower than 12? Did anybody get a number over 14? What's that? 18, interesting. Let's look. What is there?
Yes. Yeah. So the measurements, if I was looking at this, I would get somewhere between 10 and 14.
Okay.
Right? You can have some variability on.
Oh. I like the.
Yep, each tiny box is 0.04.
So after this one.
For your test, guys, I am not gonna ask you to give me a measurement of the number, okay? But you're gonna need to know how to measure these, because if you don't know what's normal and what's not, it's gonna be really hard to interpret what rhythms they are. Okay, so please, don't let that stress you out. I'm like, oh my gosh, I got 10, or I maybe got 9, or I got 17, right? Like, I'm not gonna ask you specific measurements, but I do want you to know how to do it. On the next exam, there will be EKG like these that you'll have to tell me what the rhythm is. Or I might even say, you see this rhythm on the monitor. What would be the next step for us to do? Right? We're going to talk about some of these. All right. Are you guys ready for a break? Yeah. Okay. Let's take till 15 after. Okay. So 11:15 and we'll come back. So the thing I want you guys to notice is that sinus bradycardia is slow and sinus tachycardia is fast, right? They're both coming from the sinus node. They're both coming from up here. One's just slower, one's just faster. So what do we do about it? Well, first we want to look at our patients. Sinus bradycardia, if it truly is a dysfunction, it's not just somebody with a really healthy heart, that person's probably going to be fatigued and tired because they're not getting the blood pumping where it needs to go. So if they're asymptomatic, we don't treat them with anything. If they are symptomatic, we want to get them some oxygen, they might get some dopamine, or they might have pacing, which is where we put, like you guys know, like in the movies when they're like, oh, my heart's beating weird, shock them, right? That's a cardiover, or that's a defibrillation, but it's essentially electrical current they're sending into the heart. We can do little pacing, boop, boop, put some pads on, and we can send a current to the heart to make it start beating. We'll talk more about that in a little bit, because it's not very comfortable. Sinus tachycardia, here's a picture of it. Oh, Lordy. Let's get back to where we were. Look how far we went, guys. Look at you, good job. So sinus tachycardia is fast, right? What might somebody feel if they have sinus tachycardia? Breath, they might feel anxious. Sometimes like, I feel like my heart's pounding out of my chest, you know, they might feel some symptoms there. So if they have a issue, they're actually symptomatic, we want to treat the cause. What is causing them to have a higher heart rate? Sometimes if somebody is very dehydrated, they maybe have lost a lot of blood in a trauma, their heart rate is going to go up to compensate. Remember, cardiac output, that's how much blood is pumped out of the heart from the ventricles times how often the heart pumps. So if we're not pumping out very much, we're going to increase that heart rate to try to catch up a little bit. We might give them some medications as well. And we're going to go more into medications next week. So we're going to talk about some atrial arrhythmias, right?
So now this is where beyond just the sinus node, the atrium's being really funny. It's acting out. So first of all, premature atrial contractions. In this, you can see you have what looks to be a nice normal sinus rhythm, nice and regular. But all of a sudden, like if I measured this out, I'm like, okay, QRS to QRS, normal, that's same, that's the same. Whoa, what just happened? I just found an early one. But okay, as you can see, oh, here we go back to being the same. And here's another one. What happens is when you can look at this and I go, well, occasionally there's these extra beats that come in early. They have a P wave in here. I don't really see the T wave. The T wave's a little inverted. It's kind of going down. But I have this extra P wave and a QRS. That's called a premature atrial contraction. Sometimes our hearts get irritable and we just go ahead and send an extra signal through. And so if the rest of the rhythm looks normal, it looks just like sinus rhythm, but every once in a while we have this extra beat and it's got that nice P wave and a real small and tidy QRS complex. That's an extra atrial beat that happens. Okay, it's called a PAC, premature atrial contraction. So they interrupt the rhythm. They're usually, it's usually not a problem for patients unless it's happening frequently. Then it's really disrupting the rhythm. And then you might have patients that feel a little bit different, but usually not unless it's frequent. Bum, bum, bum. Okay, another atrial arrhythmia. Now I want you to go to your place on your sheet where we have atrial flutter. Now, a lot of times patients, not my patients, my students will get mixed up with atrial flutter and atrial fibrillation. I'm going to tell you now, atrial fibrillation is a lot more common to see, but we're going to start with looking at atrial flutter because it's real easy to identify. Why? Because you have these beautiful sawtooth P waves that march along here. Sometimes it's called atrial flutter because they used to say it kind of looks like butterfly wings, but the P waves are very definitive. They're usually kind of peaked. And with atrial flutter, it's usually regular for the rhythm. So look at your atrial flutter and let's measure the QRS interval. So from the beginning of one QRS to the next, I want you to measure that for atrial flutter and see what we get for regularity. Hey, do you want to practice measuring? But you can't, yeah. So. Yeah, I thought she said. No, sorry, it should be regular. Yeah. So what do you guys put? Does this look to be regular or irregular? Regular. Regular. In fact, when you look at the flutter waves, is there a consistent amount between each QRS complex? If you count them on this strip, I think this might even be the same one. There are 4 P waves. 1, 2, 3, 4. 1, 2, 3, 4. 1, 2, 3, 4. Each QRS complex has 4 P waves, like between each one. That's very common with atrial flutter. What's happening in the atrium is that instead of sending this organized signal down where it has one big contraction, it's kind of doing this, like it's kind of like it's moving, it's getting the job done, and it's still like in this regular pattern, but it's like they like took too much caffeine or something, right? Atrial flutter is usually regular. They call this a 4-to-1 contraction, meaning there are 4 P waves to every 1 QRS. Sometimes you might see 2-to-1, 3-to-1, 5-to-1. You're just counting. It should be it should all be the same, right? You're counting out the same number of P waves between each contraction. All right, let's go. Just because we had so much fun measuring this, let's measure our atrial fibrillation, that rhythm that's right below. Measure from the first 2 QRS complexes and see if those measure out regularly.
They don't.
Yeah. Because you can kind of look at it and tell, right? So we can tell that that next strip is irregular. All right, so looking at our atrial flutter, how do we know if something is atrial flutter? Well, first of all, it just look like atrial flutter. If you know to look for those, they call sawtooth, like you guys know, like a saw that you use to like saw wood,
Yeah.
like it has those sawtooth patterns, and it should be regular. The PR interval, we can't really measure it because we don't know which of those P waves is really finally sending the signal through to the ventricles. But the QRS complex is still nice and tiny and skinny. It still looks good. They might have palpitations if their rate goes up. Now, the rate that we have, what is our rate for our atrial flutter? If we count the QRS, 90, are there 9 QRS complexes what I'm looking at? Yeah. So this is still within a normal heart rate. But you can have atrial flutter that's like 190. Well, that'd be pretty hard to. But you know, usually it's not that high. Usually 120, 140, something like that. They might have some palpitations and not feel very good. So we're going to treat them. If they're going too fast, we might do cardioversion. So just like in the movies when they're like clear, doof, when they charge somebody, right? That's a defibrillation. You guys all learned about defibrillation when you took basic life support, right? They talk about putting on an AED on somebody, and then the machine kind of takes care of it. For cardioversion, that is a synchronized electrical signal that we send. And we don't have to choose. I'm so thankful. Years and years ago, we would have to look at the signal because what you don't want to do is push a big electrical impulse right as our ventricles are contracting, because we might just totally malfunction the heart and we might die. I mean, they're already but what we did, we have the machine pace it out so it doesn't give that signal at the wrong time. It's not very comfortable to patients. I've been with patients. My dad actually a few years ago when he was visiting had to go have a cardioversion here because he started not feeling good. And he was in a fib, not a flutter, but his heart rate was up in the 160s and his blood pressure was going down and he was not looking very good. We had to go to the hospital and they had him hooked up, and fortunately they could give him a little bit of medicine, relax him, and they gave him the cardioversion. And it essentially restarts the heart, right? It's an electrical current. So if you can kind of restart it, fortunately for him, it started back in the sinus rhythm. It doesn't always, but a lot of the time it can. If it's an emergency, we will give the medicine to help relax them for pain, because it hurts. When you take these off of patients, those patches, oftentimes the skin underneath, it's like a sunburn. Like it kind of is irritated, it's reddened, it hurts a little bit because of that electrical current that goes through. So if we can give them medicine to help relax them, help with some pain beforehand, like with my dad, we absolutely will. But if my dad was like passing out, if he just was not, like, we don't have time to go get this medicine, he's really not feeling well, we'll go ahead and cardiovert without giving medicine or anything to like help the patient with pain, because we want them to live, right? I'd rather have an alive patient that maybe was a little uncomfortable than somebody to die while we're waiting to get them some medicine for pain and to relax them. Seems kind of harsh, but if they're that bad, they're probably not going to remember what's going on because they're real sick. So cardioversion, that's if the heart rate is very high and the patient's not tolerating it. How do we know if a patient's tolerating the high heart rate? Oh man, I wish I could understand. You guys, I could tell there were a lot of good answers. Maybe a little louder. An assessment, they're relaxed. If they're symptomatic, right? Because if they're relaxed, like they're passed out, that's too relaxed, right? I'd also want to look at their blood pressure, right? So remember cardiac output, that's how much is getting pumped out of the heart by how often. And if oftentimes when we're pumping really fast, we're not getting much that's going out to the system and your blood pressure drops. If the patient's tolerating it okay, we might do some medications for them. My dad also went into AFib another time a few years before, and he was able to go to the hospital and they gave him some IV medicine, and that was able to convert him out of the AFib into a sinus rhythm. Now he takes medicine to use, I think it's a beta blocker that he takes regularly, but he still will go into AFib every once in a while. And he knows when he does because he'll go, I feel horrible. He gets pale, he gets sweaty, he feels fatigued, he does not feel good.
But people that are like diagnosed with AFib, are they constantly in AFib? Or they like, my grandma has AFib, you know, that means that she's constantly.
That's a great question. So the question was, is somebody, if they're diagnosed with AFib, are they always in AFib? And the answer is no. It depends on the person. There's some people, they're in AFib and they live there. Their heart, because I mean, the electrical currents, once you establish these pathways, our heart likes to go back into those pathways, right? That's why we like to keep them in a good pathway. But if somebody is in AFib for a while, sometimes we try, but we can't get them out of AFib and they live there. So we give them medicine to help slow their heart. We give them medicine to help reduce other complications, but they just live in AFib. Some patients have paroxysmal AFib, meaning they go in and out of AFib, like my dad. If you check him, I got him an Apple Watch so we can check his rhythm and send it to me, because sometimes he's like, I don't feel good. I'm like, okay, Dad. He doesn't live close by. He lives in the Midwest. So I'll say, okay, Dad, take your heart. Let me see, send me your EKG. Let me know where you're at. Sometimes he doesn't feel good and his heart rate is fine. He also has diabetes, so oftentimes the blood sugar issue. Other times his heart, I'm like, he's in AFib again. And so we talk about, okay, you got to call your doctor. How are you doing? So you can go in and out of it. It just depends on the person. An ablation, a cardiac ablation, because some patients have really established those rhythms where they're abnormal. They usually are atrial fibrillation, sometimes flutter, but it's usually our patients with atrial fibrillation. They've established these patterns that are abnormal. And so they can go in and kind of essentially burn away some of those pathways. And so then it can establish where the heart goes to new normal pathways. So not everybody's a candidate for that, but sometimes you can have a cardiac ablation where they try to stop the heart from going in those abnormal pathways. All right, so atrial fibrillation. We're looking at this, you can tell there's a big difference in these P waves than the atrial flutter waves, right? Like, look how tiny they are. When I think fib, it's just like just, it's like hardly anything. They're not consistent. Like even the size of these little P waves, it's just like scribbles, right? And then when you're looking at the regularity, is it regular? No, it's irregular, right? So AFib, that's one of the big things, is it's irregular. We can't really see P waves very well, so we can't count the PR rhythm, but we still have this nice small QRS. When we have a small QRS complex, that means we're still getting a signal from up here somewhere in the atrium. That'll be, the reason for that will be more apparent soon. So with atrial fibrillation, we often talk about if it's a controlled response or a rapid ventricular response. What that means is a controlled response might be, let's see, what was this part right here? Did we say it was 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this heart rate would be about 100. This would be a controlled response. It's the high end of normal, but it's still within normal. We might have where all these P waves, they're just kind of, the atrium is just kind of like fritzing out. It's just sending these random rapid signals. and they're not always consistent with what goes through the ventricles. Now, with the rapid ventricular response, that means a lot of those signals are getting down. And so you'll have really fast heart rates up to 180, 200, which are just this, the atrium are just spazzing out and the ventricles are just trying to keep up. That's what a rapid ventricular response means. The ventricles are trying to keep up with it. Dun dun dun. So they might have palpitations, they might feel faint. When you feel their pulse, oftentimes it's kind of a weak or thready pulse. They're usually not able, especially with the rapid response. Again, that cardiac output is usually low. We're not able to feel their pulses as well. Again, we might do that synchronized cardio version if they're unstable. If they are stable, usually if it's a controlled rate, we'll try to give them some medications to keep that heart rate nice and stable, keep it from getting too high. We also want to anticoagulate these guys. You know why? Blood clots from the blood left in their heart. Normally, this atrium, we get a nice good contraction and all the blood is moved, or most of the blood is moved down to the ventricles and goes out into circulation. When you have the atrium that are just kind of spazzing out, you're not getting all that blood pushed through effectively. And some of that blood just kind of sits in the atrium. It's not just sitting there still, but it's just not moving around very well. And we know that blood has a tendency to clot if it's not moving through something well. And so patients can tend to form blood clots in their atrium because it's not getting pushed through normally. So we usually have them on some sort of long-term anticoagulation if they have AFib, because we want to prevent them from having blood clots. Because remember, the pathway through the heart, if a blood clot goes through to the ventricles, where is it heading next? To the lungs. You guys know what the blood clot, the lungs is called? Pulmonary embolism. Yeah, it can cause some acute lung dysfunction. Okay. Activity cue. You're listening to the apical pulse of Miss Willis, 76, and she's dehydrated. And now it's irregularly irregular. You guys know what that means?
It's not usually irregular.
Right. So instead of having a thump, 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 that is regularly irregular, right? Because it's following a pattern. If it's just thump, 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 bump, 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 bump. Okay, I can't sing, but right, like if it's just randomly, you're like, there's no pattern to this. That's irregularly irregular. What action do we take? Yeah,
Start
check the
doing-
patient, do vital signs. Do we have an EKG? Notify the provider. Yeah, absolutely. These are classic symptoms of atrial fibrillation. I remember when I was working night shift and I was just ready to get off and my nursing assistant came up and she goes, "This patient's heart rate is 140." And I was like, "Oh, you were good all night long." And it's 6:50. Now this has to be. And I went and I listened to her and she was irregularly irregular. And I was like, oh, now I know I'm going to be late. And I called the provider. I went and checked on her. She didn't feel very good. Blood pressure was going down. We called the provider and he ordered, she wasn't on a heart monitor. So he ordered a 12 lead EKG and she had started going into atrial fibrillation. Unfortunately, the new nurse came on and I was able to give handoff and I was still late getting out of there from all of the things. So I didn't have to stay. But I think they went ahead and tried to do a cardioversion on her later that day. I don't know how she resolved because I floated to a different unit. But I remember being like, oh, great. She's irregularly irregular and her heart rate's really high. That's probably atrial fibrillation. Okay. Which of these are the rules for atrial fibrillation? Is it irregularly irregular? Now select all to apply. Atrial rate isn't measurable, meaning you can't really measure the P waves. No identifiable P waves. PR is measurable and the QRS less than 10 seconds. It's one. So let's go one by one. Yes or no for irregularly irregular?
Yes.
Yeah, yeah, right? Heart
rate, the atrial rate is not measurable.
No.
Yeah, it's not measurable, right? Correct answer is 1, 2, and 3. Make sure I'm right. Yeah. Three P waves. With atrial fibrillation, we can't really see the P waves. We just see the squiggly line. With atrial flutter, that's where we have that sawtooth wave pattern. We can measure atrial flutter waves, but not with atrial fibrillation. Now, PR interval, is it measurable with AFib? No, so we can't really see those P wavelets. We can't measure how long from the P wave to the QRS. And then the QRS complex, is it nice and tidy? 10 or less? Yeah, it is. So that means that it's atrial fibrillation. Good, guys. Okay, we are gonna cover one block, and that's 3rd-degree heart block. And all that means is that essentially the heart, atrium is the wife, ventricles are the husband, or whichever way you want to identify them. But they are doing their own things. They've decided they gotta live in the same house, but they're not gonna be doing anything with each other. Okay? So what that means is the atrium, which what do we look for on the EKG? What shows us what the atrium are doing? Which wave? The P wave. The P wave are doing their own thing. So if we measure out the P wave, here's our P wave, and I think you have it on your cheat sheet too. I think you have the 3rd-degree block. So if you look at it, the P waves, we could measure it where it's equal. Here's a P wave and another P wave. And if we move over here, oh look, you might think that's a T wave, but it's not. Still here. Ooh, look how this looks different. It's because my P wave is hidden in here. And then if I move on, it's still the same. The P waves march out the same all the way through. The QRS complex also marches out where it measures. But if I look at the PR interval, and here, there is no consistency. They are absolutely ignoring each other. So a 3rd-degree heart block, you're also going to notice what's different about this QRS complex from what we've been looking at. Very wide. A wide QRS complex usually means that the signal is happening somewhere below the AV node. So that complex is beginning in the ventricles. So we've got spouses that are doing their own 2 different things. Usually it's a low heart rate because the ventricles are only going at their own pace. They're like, you're type A, I'm type B. You do your thing, I do mine. The P waves are going to march out as being equal. The QRSs are going to march out as also being equal, but there's nothing that's consistent. There's no consistent PR. There's nothing that says that each PR would match up to, or a few PRs would match up to the QRS. All right. Somebody who's in a 3rd-degree heart block, if we see somebody with that, they are sick. Because what's the heart rate on this patient right now? 40. And when your heart starts not talking to each other, the different parts, that means you're in trouble. These are patients who usually need like a pacemaker or something to go on. So if you see somebody who's suddenly in a 3rd-degree heart block, we know that's bad news. We need to go check on them, get their vitals, notify the provider, probably prepare them for like some pacing. Talked about this. So causes, it could be from like a heart attack. It could be from some of the medications like digoxin, too much digoxin. Sometimes with aging, right? Our muscles, our organs tend to start breaking down after time. And this could happen as we age. Symptoms, dizziness, syncope or fainting, shortness of breath. What do we do about it? So we might do, like we talked about, they might need a pacemaker, but we might do temporary pacing as well, which just like you have patches that you'd put on somebody, like with an AED or defibrillator, you can actually do pacing through those. Usually I've only seen it done in the ICU. You won't have to do it elsewhere if you're in the field somewhere maybe to start it, and they do.
through those patches, not very fun for the patients. Usually they sedate them. Who wants to be shocked over and over and over and over? It's a very short timeline that they're doing the temporary external pacing. External meaning outside of your chest. Usually it's like, hey, we got to get this person into the cath lab or surgery. We want to get a pacemaker, permanent pacemaker put in for them. Okay, so now we're going to talk about ventricular arrhythmias. We've been talking about atrial arrhythmia. So a heart that is, or a beat that's coming from somewhere in the atrium. Now, these are beats that originate, or really they start in the ventricles. And remember, the ventricles, it takes longer for everything to move through here than if it was sent from the sinus. And that's why you have the wider QRS complexes. So anytime you see a QRS complex that's not tidy, it's nice and wide, you're gonna know, oh, that's from the ventricles. That's a ventricle rhythm. So there are premature ventricular contractions. Just like we talked about, occasionally patients having premature atrial contractions, you can have premature ventricular contractions, which means all of a sudden you have this nice kind of pretty rhythm, and then the ventricles just decide to send a beat through. They can be either, they can originate from different spots. So whatever spot in this ventricle that's sending the signal, then make it look a little bit different on our rhythm or on our sheet. Let's say the rhythm, this spot right here gets kind of irritable. Then we might see it deflect up and then down. But maybe this spot over here gets kind of irritable and it's in the signal. Maybe that deflects down and then back up. So they might look a little bit different. See how you have one PVC deflecting up, and here's one deflecting down. If they all are going the same way, if they're all like on the top one, all those PVCs are deflecting down, right? Those are called unifocal. That means there's just one spot, the heart, that's kind of irritable. Sometimes they will deflect up and they'll deflect down. And that means there's a couple different spots that are irritable. And that's called multifocal. Which patient's more unstable? Multifocal. Yeah, it's got more issues, more areas of the heart that are just wanting to act wild. Okay. Sometimes you'll have where you have frequent PVCs. Bigeminy is where every other beat is a PVC. I had this happen to me once. No, I had trigeminy, where every third beat was a PVC. I checked on my watch. So I was like, I don't feel good. Something does not feel right. If I drink too much caffeine, my heart starts doing weird things. And I remember sitting there and I have my little Apple Watch doing my little EKG, and I would go regular, PVC, regular, PVC, regular, PVC. And I didn't feel good. I felt like every time I peeped the PVC, I would feel like, and I did not feel good. And it like freaked me out. I felt anxious. So I know I still drink a lot of coffee, but I used to drink a whole lot of coffee. So I really decreased how much coffee I drink, because you think about coffee, it's a stimulant, right? It can really irritate some of our systems, especially our cardiac system. Couplet PVCs, that's when there are two of them together. So you have your regular beat, boom, boom, PVC, boom, 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 PVC, and it might not happen all the time, right? Sometimes you can scare somebody and they're like, oh, my heart jumped. That stress might have actually triggered a PVC. So we don't know unless we have them on the monitor and we could actually see them. A run of PVCs, 3 or more in a row, gets kind of scary because it starts looking like VTAC. We'll talk about that in a second too. Nope. Okay. Oh, this is bigeminy. Every other. Okay, ventricular tachycardia. Now, if somebody is in ventricular tachycardia, they are not doing well. We want to look at somebody too, because there's 2 types of ventricular tachycardia. You guys know what types there are? Kind of alive or dead. what you really call it is pulseless or with a pulse. Okay, because when our heart goes into VTach, there are some times when patients walk around with this and they still have a pulse and they'll talk to you. They're usually not feeling very good, but they're with you. They're not going to be with you long unless we do something about it. There's other types of patients who they go into VTach and they do not have a pulse. They are not perfusing. If that ever happens, what do? We call a code, we would start CPR. We actually don't shock pulseless VTach. So anyway, so you can see how this person went into VTach and then they went out of VTach. Now, when we're looking at this VTach here, do we see P waves inside of this rhythm, just the VTach area? We can't see. The ventricles are going too fast to even see if there's anything happening in the atrium. What about the QRS complex? Is that nice and tidy or is it wide? It's wide. So we know since it's wide, it's coming from the ventricles. How fast is that right here? Well, I do about 18, just right on here on part of the 6-second strip. That's pretty dang fast. This patient is probably not feeling very good. You can't have somebody who can go in and out of VTach. This is called what I call a burst of VTach. They probably, I mean, sometimes patients will pass out if this happens. They don't feel very good. Something goes on. If we can catch it on the monitor, it's real good. Because then we can say, look, we found it. This is what happens. If it's slow VTach, it's less than 150. Typically, you guys are going to have fast VTach, which is 150 to 250 beats per minute. They are dizzy, their heart's fluttering, they don't feel good. Most of the time, it's right before they enter cardiac arrest, where their whole heart stops. Pulses, oh, I said that backwards. I think I said we don't defibrillate pulses VTach. It's if they have a pulse, we don't defibrillate because we don't want to stop whatever the heart is. We might give them some medications. If they're stable, we'll try to get something to kind of steady that rhythm of the heart. But generally, if they don't have a pulse, we're just going to start CPR. We have a code team, and we're going to ask them to come in and help us out. This rhythm is called ventricular fibrillation. Kind of looks similar to AFib, like the atrial part of it, like where we don't have any, like we have these QRS complexes, but they're a lot smaller. And the reason why I said it looks similar to AFib is that on AFib, you have the definite QRS complexes, but you have that little squiggly with the atriums. That's when the atrium are like fibrillating or kind of mushing around. This is when the ventricles are starting to mush around. It's not an effective heartbeat. Can't even really measure how fast it's going because it's not, we can't really measure them. They're not definitive really enough to. And remember we talked about on our paper, horizontal measures time and vertical measures the impulse, how strong the impulse is. This is very short. This is not a very strong electrical impulse. That tells us the heart's just barely hanging on. Usually these patients don't have a pulse and we would want to start CPR on them. Then we also have asystole. Asystole means nothing's happening. A lot of students get confused. They're like, but I see something there. This is what we call nothing. It's called asystole. If you have more definitive, it looks more like this, that's deep fib. But if you have anything less than this, and it just has like little irregularities, that's asystole. Asystole doesn't look like the TV shows where it's this beautiful flat line that does nothing. That's not what it looks like in real life. It will look like this. Okay, asystole, they're dead, right? Their heart's not beating. We're gonna do CPR, see if we can help bring them back a little bit. Pacemakers. Here you can kind of see a little bit. I know I'm kind of going fast. Sorry, guys. Pacemakers will usually live on the left side of the chest. This one shows them on the right.
you have a patient, when you guys are going to clinicals, you have a patient with a pacemaker, I want you to palpate their chest because you can feel the pacemaker. You plant it under the skin, and it's usually about this big. It's this hard, like plastic usually piece, but you can feel it. And it has these pacemaker nodes that will come down and they attach into the heart, and that's what sends the electrical signal, right? Because their sinus node or their atrioventricular node isn't working like it should. When we have pacemakers, sometimes you only need to do a sinus pacemaker. And then the heart's working well enough, it will send the signal down and the whole heart will beat. Other times, the AV node is damaged too. You might have to signal both of them. You know which one, what type, by looking at the rhythm. Remember, it's the impulse, how much electricity is going through. The pacers have spikes. So see, right before the P wave, there's that big spike that goes up there. That's called a pacer spike. So before every P wave, on the top one, there's a pacer spike that sends the impulse, and then the heart. Now here on B, this is a ventricular pacing. So right around the AV node, it's sending the signal through, and then the ventricles are pacing. The last one is AV or atrial ventricular pacing, where it's actually sending a signal to both atrium and ventricular. I'm not going to test you on pacing. I just want you to kind of know what they look like. One thing with our patients when they have pacemakers, we want to make sure they know what to monitor for, right? If they start not feeling well, they want to make sure they know how to count their own pulse because it might not be working. We want to make sure they know how to monitor for infection after they've had it put in, right? Monitor that site. You know what to look for signs of systemic infection. Make sure they know what kind of pacemaker they have. Almost all the pacemakers now can go through like MRIs or be scanned. You know, back whenever it used to be metal, and like you don't want to put somebody with a pacemaker in an MRI, right? That would not be safe. Microwaves are safe, right? But you never know what patients know or don't know. They might think, can't use a microwave anymore. I better get rid of all my refrigerator magnets. You know, they might just not know. It is true, there are specialized magnets that we do put over pacemakers that suspend the pacemaker from working. That's how we're able to check to see what is the heart doing when the pacemaker isn't going. You never want to put that on. Yeah, you don't ever want to put it on without a doctor's order, and usually with a provider kind of there with you or somebody who knows what they're doing. But usually in most facilities, if you have usually they'll have a pacemaker magnet somewhere. You can ask if they have one. They're big, they're heavy. Don't ever put them on your patients without asking. But that way you can see what the rhythm is without the pacemaker. We talked a little bit about defibrillation. This talks about paddles. I have not seen paddles used for 20 years. You use patches. Patches actually can adhere to the chest much better. And so that's what you want to use. We always want to announce clear for safety. Why do we do that? Right? Because what is clear signal? Hands off, right? You don't say clear and shock. You say clear. And then what I was trained is that if I'm the one going to shock, I'm gonna say, okay, everybody clear. Everybody around the patient goes clear, and they step back to ensure that yes, they are clear. Because if you're dealing with the patient and you're still touching something and with shock, what happens? You get a second patient because now I'm on the ground, you know? So you want to make sure if you ever have to be part of that everybody is safe. It is true when you put on pacemaker patches, you usually want to go up and down. With kids, it's a little bit different because they're smaller. If you have to defibrillate kids, and you might have to someday, depending where you work, you usually go through front of chest and back of chest. Because what you want is it's sending the electrical current through the heart. So that's why we're kind of encasing the heart with a patch here and a patch here. With kids, they're so little front and back. And we want to make sure we use specialized patches for the kids. I have specialized machines. They send lower voltage of electricity because kids are little. They don't need as much electricity or joules as we would need. Bum, bum, bum. Okay. Okay, that was it. Oh my gosh, you guys, there was so much we didn't even get
ready for. I'm so sad. Next week, we're gonna do some games with rhythms to help you check to see how you do with them. I will review the test. If you guys, do you want to take a little break and review, or do you want to just review now? Review now? Okay. Let me stop my recording.